I'd like to thank the organizers of the conference for the opportunity to present some additional data on long-acting injectable Cabotegravir for HIV PrEP, focusing on resistance and breakthrough infections. I think everyone is aware from the prior presentations that this is the study design of both the HPTN 083 and 084 studies, which enrolled participants who were at elevated risk for HIV infection and randomized them at a 1-to-1 ratio into either a Cabotegravir active arm that also administered a TDF-FTC placebo, or a TDF-FTC arm that also administered a Cabotegravir placebo. That oral phase followed by in a direct oral injectable comparison was designed to last approximately 3 years, and individuals who stopped Cabotegravir injections prematurely received an additional 48 weeks of open label TDF-FTC to provide ongoing PrEP. These were the original pre-specified analyses of the primary endpoint that we presented at the AIDS 2020 conference in July of 2020 from the HPTN 083 study, wherein we found 13 incident HIV infections in the Cabotegravir arm for an incidence rate of 0.41 compared to 39 incident infections in the TDF-FTC arm for an incidence rate of 1.22, resulting in a hazard ratio of 0.34 with 95% confidence bounds that clearly excluded the pre-specified non-inferiority margin of 1.23 and the superiority bound of 1.0. As we were doing this primary analysis and subsequent work, we became aware that Cabotegravir seemed to have a profound ability to suppress viral replication in the context of both prevalent or baseline and incident HIV infections, delaying diagnostic testing-based identification of those HIV infections by conventional testing algorithms. This was what was pre-specified in the HPTN 083 protocol. On the left side of the slide, you can see what was done at the sites. So all participants at every visit were administered and received a rapid point of care antibody test, as well as a 4th or 5th generation antigen antibody test that was done in a lab-based setting. Participants also received an HIV RNA test that had to be not detectable within 14 days of original trial enrollment. Additional testing that was pre-specified was done retrospectively on stored samples from all participants, and it was performed at the Johns Hopkins laboratory at the HPTN Laboratory Center. These included a 4th generation instrumented antigen antibody HIV test that was an architect test, a confirmatory or discriminatory test that was a genius test, an Aptima qualitative RNA test, and back testing using the Aptima qualitative RNA assay until it was negative at least 1 visit. What we learned because of these prolonged and profound suppression of the existing testing algorithms was a need to do the following additional testing that was added post hoc. In addition to the 4th generation confirmatory or discriminatory and Aptima qualitative testing, we additionally back tested using the Aptima qualitative RNA test all the way to enrollment for the Cabotegravir seroconversions, and a bookended sandwich approach for the TDF-FTC cases. We did additional quantitative RNA viral load testing as well. At the AIDS 2020 conference, we showed this diagram, which bucketed the, at that point, 13 incident and 2 baseline HIV infections that we found in the HPTN 083 study. We gave them names based on what bucket we thought they fell into in terms of an explanatory model for the breakthrough in the PrEP. Cases A1 and A2, in fact, were not breakthroughs, as retrospective sensitive laboratory testing identified these infections as pre-existing before any PrEP agents were administered. 5B cases, if you will, represented cases that occurred after a prolonged hiatus from last Cabotegravir administration. And I would point out that in all 5 of these cases, as you can see represented by the green virus emoji, as well as the black asterisk, that the site-based testing as well as the centralized laboratory testing were identical. There was no delay in detection at the sites compared to the central laboratory testing. For the C cases, these were cases where the virus was first identified in the central laboratory testing during the oral lead-in phase, but in 2 of the cases, C1 and C3, were not detected at the site until active cabotegravir injections had already been administered. And then the D cases represented at the time 5, and I'll tell you more about that number in a moment, cases where breakthrough occurred despite, as far as we could tell, on-time cabotegravir injections. What we learned using the additional retrospective back testing was that we were able to find evidence of HIV infection using this Aptima back testing past the first 1 negative Aptima result on the stored specimens in at least these 2 cases that I've highlighted here in red, D2 and D5. And I'm going to ask you to follow with me in this animation that I've created where I show you how the green virus emojis in these 2 cases was relocated with the additional back testing. What you'll notice in particular is in the D5 case, now evidence of viral replication was found before any PrEP products were administered, meaning that D5 was appropriately recategorized as A3 rather than D5. So we went from 5 D cases to 4 and from 2 A cases to 3. Using this additional back testing, we also identified an additional baseline case that we've called A4, and bringing the final tally for the original period of pre-specified observation to 12 incident and 4 baseline or prevalent infections in the cabotegravir arm. What this did is it took our initial estimate of the incidence in HIV to include 12 infections in the cabotegravir arm, updated in the orange bar now with red writing on these slides for an updated incidence rate of 0.37 per 100 person years in the cabotegravir arm and a hazard ratio of 0.32 with an unchanged interpretation. In HBTN 084, which was done in cisgender women in sub-Saharan Africa, similar findings have been presented by my colleague Sinead Delaney-Moretlaway from the Wits Institute in South Africa. In that study, they found 4 incident HIV infections in the cabotegravir arm and 36 incident infections in the TDF-FTC arm for an incidence rate in the CAB arm of 0.2 per 100 person years and in the TDF-FTC arm 1.86 per 100 person years, also a superiority result. These are the 4 incident infections in the HBTN 084 study. You can see 2 of them represented B-type cases after prolonged hiatus from cabotegravir administration, and 2 D cases which occurred in the context of ongoing cabotegravir injections, although the D1 case, there appears to be some inconsistency in the intervals between some of the injection visits. The pharmacokinetics and resistance from the 084 study are still in progress, and I will not be able to share those with you today, but Dr. Delaney-Moretlaway hopes to present those at an upcoming conference in the not too distant future. Again, the B cases are categorized the same way as in the 083, as are the D cases. So what did we learn when we actually looked at the pharmacokinetics and resistance profiles of the 083 seroconverters from the cabotegravir arm? We learned from the group A cases, and if you remember, those are the cases where HIV infection was detected prior to the administration of any PrEP study products. So those who were HIV positive on retrospective testing at study enrollment. This is what we learned. We learned that if you don't diagnose HIV prior to PrEP agent initiation, that is, if you initiate pre-exposure prophylaxis during the acute or eclipse phase of the infection, CAB can make it challenging to diagnose later by virtue of potency of virologic suppression and delays in conventional antibody-based testing. Viral load is lower, and it may even be undetectable. Aptima qualitative RNA testing or quantitative RNA testing was the test that was found to detect infection the earliest. And the point of care or rapid and 4th or 5th generation antigen antibody laboratory-based assays were delayed in turning reactive and would sometimes flicker, meaning they would be positive and then negative, so-called reversion. Failure to diagnose HIV infection in this context can lead to continued cabotegravir administration and even continued cab injections after the oral lead-in. What we found was that with concentrations of cabotegravir that are high, if HIV viremia escapes cabotegravir control, it can be cabotegravir resistant. We had one such case in HPTN 083. But when the virus escapes, that is, you get breakthrough viremia when using cabotegravir during its pharmacokinetic tail, it did not generate cabotegravir resistance. We had one case that interrogated that and resulted in wild type virus. What did we learn from the group B participants in the cabotegravir arm of 083? Remember, those are the participants who had no recent cabotegravir exposure. What we learned is the following. We learned that if you don't take cabotegravir, it doesn't prevent HIV infection. I don't think that's a surprise to anyone. We had 3 participants who acquired HIV during the cabotegravir pharmacokinetic tail, and it did not result in cabotegravir resistance. While this is reassuring, it does not rule out that the cabotegravir pharmacokinetic tail is something that we need to keep an eye on. We need more data. In at least 2 cases, where individuals in the study were provided open label TDF FTC to cover that pharmacokinetic tail, they had no pharmacologic evidence that they took that TDF FTC, and that absence of TDF FTC likely contributed to the susceptibility to HIV acquisition. What did we learn from the group C cases from the cabotegravir arm of 083? And to remind you, those are the cases who on retrospective testing we identified as having acquired the infection during the oral lead-in period. This is what we learned. If you don't take oral cab, it doesn't prevent HIV infection. We don't know how forgiving oral cabotegravir is to missed doses, certainly not in the same way that we do for TDF FTC-based PrEP. There is a likely time to onset of protection with oral cab that is yet to be defined. And cab delays new HIV detection, that is incident HIV detection, by delaying the reactivity of conventional testing, and cabotegravir injections can inadvertently therefore be provided as monotherapy despite someone actually being HIV infected. As we saw with the A or baseline cases, viremic escape at high cabotegravir concentrations can lead to cabotegravir and other class integrase resistance. So what did we learn from the group D cases? And if you remember, these are the cases where infection occurred in the setting of on-time and concentration as expected cabotegravir injections. What we learned is that delays in HIV tests occur detecting new infections in all 4 of these cases. As I mentioned, the cabotegravir concentrations in the blood were as expected from previous studies. So therefore, it wasn't unexpectedly low concentrations of cabotegravir that explain the PrEP failures or breakthroughs. If HIV is acquired in the context of high concentrations of cabotegravir and the HIV smolders in the context of that breakthrough, it can lead to cabotegravir and other integrase inhibitor resistance when viremia breaks through and escapes that cabotegravir monotherapy. We do not yet know if that resistance can be avoided by earlier detection of the HIV infection. Let me turn now to the TDF FTC arm of HPTN 083 and try and provide some explanation for why there were 39 incident breakthrough infections in the TDF FTC arm. What we learned is the following. If you don't take TDF FTC, if you don't take it at all, or if you don't take it very frequently, it doesn't work. And in fact, 37 of the 39 incident HIV infections in the TDF FTC arm that we found were attributable to non or extremely poor adherence. One was attributable to the transmission of K65R resistant virus Interestingly, the M184V mutation was not present, but other non-nucleoside reverse transcriptase inhibitor mutations were present. And one, we don't have either a genotype to help explain it, nor proximate enough measures of longitudinal adherence to fully explicate the reason for that virologic failure. So the key thoughts and take-homes regarding the breakthrough infections and resistance for the infections that occurred in HPTN-083 are here. We found that both cabotegravir long-acting and TDF-FTC were both highly effective for HIV prevention, and statistically, cabotegravir long-acting was superior across populations. Concentrations of CAB in the PrEP failures or breakthroughs, at least in HPTN-083, were as expected, but the timing of exposure and infection acquisition being really difficult to establish because of these delays in reactivity of conventional testing complicates correlation of behaviors and other potential factors that could have led to breakthrough or PrEP failure. The overall superiority result of CAB-LA compared to TDF-FTC seems to be driven by better coverage of sex acts with the injectable product compared to a daily oral product. We are now transitioning HPTN-083 and 084 to open label extensions that will be specifically designed to address some ongoing critical questions that will be needed for implementation. First, will the oral lead-in be important for the use of cabotegravir for PrEP? Because it did not seem to sieve out any safety concerns and may in fact represent a period of vulnerability for those challenged by oral PrEP taking, this will be made optional in HPTN-083 and 084 open label extensions. Because of these delays in conventional algorithm reactivity, we are testing the use of sensitive quantitative viral load testing as a primary screen as part of algorithms being performed for all participants at all visits in the ongoing OLE studies. In the setting of cabotegravir LA PrEP use, prompt diagnosis and navigation to ART services with ART initiation rapidly are probably needed to avoid cabotegravir and other integrase resistance, and therefore preserving susceptibility to WHO and other guideline first-line ART therapy. Linda Gale Becker from the Groot Schuler Institute in Cape Town, South Africa, in the follow-up of these data, and we'll be hearing from her again at this conference, really gave us all a challenge. She said that if we can create COVID-19 vaccines in a year, can we challenge the global community to make better diagnostics that will help us identify these infections that seem to be obfuscated and obscured by conventional testing algorithms by the time CAB is available? And I would extend that further and say that these increased sensitivity modalities of testing won't just be applicable to cabotegravir, but to other future long-acting PrEP agents as well. I'd like to acknowledge on the part of 083 and 084 our sponsors at the US NIH for 084, Bill and Melinda Gates Foundation, ViiV Healthcare for both, the HIV Prevention Trials Network, our pharmaceutical partners, our study teams, our program managers, community educators, recruiters, and CAB members, our sites and site teams, and our study participants, and of course you, our audience. Thank you very much for your attention.